Good day to everyone. I'm Joseph Anthony Tumbokan, and I will be the moderator for this Asia Pacific Glaucoma Society Masterclass entitled MIGS and Micropulse, Truths and Myths. This is a timely topic since there is an increasing interest and utilization of these procedures, and we must keep ourselves abreast with the latest evidence and experiences to know where they can optimally fit in our practice. Before we begin, allow me to share some benefits of APGS members, especially to those who may be interested in joining. Members of the APGS have access to a comprehensive online education platform that contains numerous instructional videos and recordings of past webinars and even masterclasses. There's free online access to the Journal of Glaucoma, discounted registration fees to the Asia Pacific Glaucoma Congress, and networking opportunities. Feel free to visit the APGS website at apglaucomasociety.org to get more information or to apply for membership. Can we have the next slide? So these are just some examples of the webinars that are available in the website. Now, moving on, it is a privilege to introduce our speaker for this masterclass, Professor Tanuj Dada. He is currently the Professor of Ophthalmology at RP Center of Ophthalmic Sciences, All India Institute of Medical Sciences in New Delhi. He is a sought-after faculty in numerous international glaucoma meetings, is very active in various regional and international glaucoma organizations, and has significant contributions to the scientific literature. He currently serves as the Secretary General of the International Society of Glaucoma Surgery, Senior Chair of the Associate Advisory Board, and Co-Chair of the Education Committee of the World Glaucoma Association. He's also a member of the Board of Directors and Webinar Series Chair of the Asia Pacific Glaucoma Society, and the Chief Editor of the Journal of Current Glaucoma Practice and Associate Editor of the Journal of Glaucoma. He has over 300 research publications in peer-reviewed index journals and has authored 5 textbooks on glaucoma. Professor Tanuj Dada is a passionate teacher, an innovator, and a well-respected colleague. Let us sit back and learn from Professor Tanuj, and I look forward to a fruitful discussion. Professor Tanuj may have some technical issues along the way, but please bear with us as we try to get him connected. Tanuj?
Thank you, Tony, for this very kind introduction. Hello, everyone. I'll just be stopping my video feed and just playing the audio. So today's topic is on micropulse laser and MIGS, truths and myths. I have no financial disclosures. And today I'll be adhering to this theme put forth by Martin Luther King Jr. There comes a time when one must take a position that is neither safe, nor politic, nor popular, but he must take it because conscience tells him it is right. So how do you choose a glaucoma surgery for a patient? The go-to procedure is that we see the evidence from randomized controlled trials and then choose what procedure to use for which patient. But as you can see, the evidence from randomized controlled trial may not always be valid, and I would encourage all of you to read this piece from the British Medical Journal on the fallacies of evidence-based medicine. And this is especially true in the modern era of the microinvasive surgical trials. And you can see in this landmark study by Dr. Baez group, of the 25 MIGS studies evaluated, the randomized controlled trials, 90% had industry funding, 60% had author shareholders, 80% had authors reporting industry association, and 60% had industry employees as authors. So there is a major conflict of interest when you are reading about these landmark trials on MIGS devices. And therefore, before you infer or start a new surgery, it's important to read literature, but you must ask your colleagues about the actual clinical experience in the operation theater. And you may find that the real-time experience may be quite different from what is reported in literature. Starting with the micropulse or the subcyclo laser, which is becoming very popular because it's marketed as a non-invasive IOP lowering therapy with excellent safety and efficacy, and especially during the ongoing pandemic COVID-19. But for our country, each probe costs 20,000 rupees, that is roughly $265, and patients often require multiple treatment. So it's quite an expensive therapy for the patient. And you must be aware that it works by basically forming a pulse laser so that the laser activity time is reduced to a cycle of 31.3% with the aim of minimizing collateral damage. It basically leads to a sub-threshold cell damage, reducing aqueous production. In addition, it may increase uvascular outflow and have a pilocarpine-like effect. The most important parameters that govern the efficacy of this technique are not only the power, but also the sweep velocity or the dwell time. And other parameters that are often not taken into account are the location of the ciliary body, the degree of pigmentation, and of course, if you're using multiple times the same probe, there may be issues with the laser calibration. And this has often been an issue about how fast do you run this probe. And with the old probe, it was supposed to be 10 seconds per sweep. But with the new probe, it is supposed to be 20 seconds per sweep with the increase in energy. And so the velocity at which you run this probe actually determines the major efficacy of this technique. And I think ideally you should be using a stopwatch when you do this micropulse laser. So currently there is a debate on the ideal spot, what is the sweet spot for this laser. And if you see the outcome, this is a multi-centile reported from San Francisco over 1 year follow-up, 167 eyes. You can see that the success rate of a single treatment is only 36.5% at 12 months. It goes up to 58% with repeat treatment. But the problem with micropulse laser is if you see this Kaplan-Meier graph, you can see the success rate goes down dramatically over time. And you can see, although there is a reduction in intraocular pressure, it is not very significant. And nearly short-term benefit is definitely there, but you have complications such as mydriasis, 15% patients losing more than 3 lines of sense and acuity, and 2 eyes losing light perception. So it is a moderate efficacy over a short term, which requires multiple repeat treatment for efficacy. Now, this is a study from the inventor himself, Professor Paul Chu, in advanced glaucoma. And you can see what they have reported is that the success rate at 1 year was 44%, and at 3 years is only 18.5% in patients with advanced glaucoma. And the most important thing to remember is that the median survival time was only 9 months. So after 9 months, and in my experience, it is only 6 months. So after 6 to 9 months, the IOP again rises and you will have to do a repeat micropulse laser. And also be aware that 14% of eyes had loss of best corrected visual acuity more than 2 lines. 7 eyes underwent phthisis bulbi, and 1 eye had prolonged hypotony. So definitely you can get serious side effects even with the micropulse laser. So what was the summary of this study? That it is useful as an adjunct procedure to other glaucoma surgeries and as an interim procedure for a temporary reduction in IOP. You need to reoperate these patients after you have done the first laser. And there is a small but significant risk of loss of best corrected visual acuity hypotony, and even thysis bulbi with the micropulse laser. Now, one important aspect that we normally ignore is the location of the ciliary body that is not taken into account in the micropulse laser. You can see in this patient on trans illumination, the ciliary body is 2.5 millimeter behind the corneal limbus. And in this patient, when you trans illuminate, you can see the distance here of the ciliary body. So it is quite close to the limbus. So you can see there is a variability in the distance of the ciliary body from the limbus, and that must be taken into account before you put any sort of probe, either micropulse or the conventional G probe for these laser surgeries. So what to do about the poor efficacy? A new technique has been advocated, MP3+, where you put 16 additional 2-second spots. But again, the success was quite less, 25% at 1 year, even with this technique. And now some authors are recommending cyclo-MIGS. That means on superiorly, you do the micropulse laser, and in the inferior hemisphere, you do the conventional cyclophotocoagulation. And coming to the safety, I would request all of you to read this article by Professor Harry Quigley. And is micropulse actually safe? You can see in this recent case report that you can have a blue sclera, this depigmentation of the sclera occurring post-laser. That is a great cosmetic problem due to scleral thinning has been reported. You have patients, if they get a subconjunctival hemorrhage during the laser procedure or during the block, that can lead to significant thermocoagulation and a very bad conjunctival scar. And that dooms your future trabeculectomy. And eyes which have got pre-existing ocular surface disorders, because you are maybe damaging the perilimbal plexus, you can get a persistent epithelial defect, and this patient actually required a tarsorrhaphy post neurotrophic keratitis following micropulse laser. And even though we may do it for elderly patients who are on anticoagulation to avoid trabeculectomy, the hypotony induced by the micropulse laser can precipitate a suprachoroidal hemorrhage. So these are all side-threatening complications that can occur after micropulse laser. But what I'm worried about is the impact of this laser on trabeculectomy outcomes. And now we are advocating, many people advocate this as a primary therapy, even for early to moderate glaucoma. And you can see the histological side effects on the conjunctiva with micropulse laser. There is a significant perilimbal conjunctival inflammation and scarring. And this may increase the risk of bleb fibrosis and failure. So that undermines the utility of micropulse laser as a primary treatment modality in previously unoperated eyes, because they are increasing the risk of failure of a subsequent trabeculectomy. So to summarize, the micropulse laser is a gentle but expensive cyclophotocoagulation, not a long-term solution to control the IOP2 target. The treatment at present is not standardized. It can adversely impact a future trabeculectomy, and most importantly, it can lead to loss of light perception and significant vision-threatening complications due to the breakdown of the blood-aqueous barrier and increase the size of the pupil. That is very important in countries which are close to the equator. And what is the alternative? So if required in a patient who is, say, post-surgery, high IOP or a failed trabeculectomy, you can go ahead with the inferior conventional diode laser cyclophotocoagulation in the inferior 180 degrees after trans-illuminating the ciliary body, and use these slow coagulation parameters 1250 milliwatt for 4 seconds. That leads to a good outcome, decreases side effects, and the superior conjunctiva is available for a future surgery. Now coming to the next topic, that is the MIGS. So MIGS stands for what? So it is also referred as the maximal income glaucoma syndicate. You can see this clip from the Wall Street. And basically, when you do these procedures, the actual term is minimally invasive glaucoma surgery. The first thing you require to do is to learn intraoperative, to visualize the meshwork during surgery. And you have a number of procedures, especially you have external subconjunctival filtration, such as the pressure flow. But the ab-internal MIGS and spectrum, CAT, iStent available, and the subconjunctival filtration such as the Zen. So the canal procedures basically are of three types. Either you can cut through the trabecular meshwork, you can dilate, or you can stent. And I recommend this very nice book by Dr. Chelvin and Keith Barton on minimally invasive glaucoma surgery to get a basic idea about all these procedures. The paradox of this surgery is that you are trying to stent or remove the trabecular meshwork. However, whenever you operate on the trabecular meshwork and the Schlemm's canal, there is an inherent healing mechanism which tries to close the fistula. And if you try to inhibit wound healing, such as with the Zen or Flow with mitomycin C, you can get hypotony and infection. And that is why it's very difficult to get an optimal outcome with any sort of glaucoma surgical device. Whenever you operate on a glaucoma patient, you have to set the target IOP. And for early, moderate, and advanced glaucoma, the IOPs are currently set below 18, below 15, and below 12. But if you want to remember one number, any glaucoma patient, the intraocular pressure should always be below 18 millimeters of mercury. That is a gold standard you must follow. So I'll start with the iStent because this has just been released in India, and the iStent Inject is costing $2,000 in India. And there are 4 variants: the iStent Original, the iStent Inject. You have the iStent W with a larger flange, and then you have now future the iStent Infinite, basically 3 devices to be implanted in the eye. If you see the initial results from the iStent compared with phaco alone, you can see a 68% control with phaco iStent and 50% with cataract surgery alone. So a very moderate increase in the IOP lowering efficacy as compared to phaco alone. And that is why it was recommended that you have to implant at least 2 devices to get the appropriate IOP lowering outcome. And this is the results of the COMPARE study, where the iStent Inject, that means 2 iStents were injected. And if you see the IOP cutoff of less than equal to 18 millimeters of mercury, that is the criteria for a glaucoma patient target IOP, only 9% of patients could achieve this target IOP. So that means if you use this device, it is not going to achieve target IOP, and most of the patients will have an IOP more than 18 millimeters of mercury. They will require additional medications to lower the intraocular pressure. And this is a very interesting study done from the Andy Marmute's group. And you can see the iStent Inject at 1 year. This is the group which had phaco with 2 iStents. The IOP decreased by 8.7%. And in the control group, which had phaco alone, the intraocular pressure decreased by 15%. So you can see even with 2 iStents, the intraocular pressure lowering is not at all impressive. And in fact, the control group is having a better IOP lowering efficacy. And the landmark thing about this study was they did the anterior segment OCT and to see the position of the iStent. And what they found was that 45% of the iStents were buried within the trabecular meshwork. So although it looks like a very simple implantation technique, but nearly half of these iStents were not functional because they were very deeply buried. And that is a major fallacy with the iStent Inject, what is available now in our country. And what could be the reason behind such a low and variable IOP lowering with MIGS devices such as the iStent is basically related to how the aqueous outflows from the eye. And that is determined by this new technique of aqueous angiography. So here you are using a tracer, which is either indocyanine green or a fluorescein, to image the outflow of aqueous from the eye. And as you do these studies, you realize that the major vessels are concentrated in the nasal quadrant, followed by superior, inferior, and in the temporal quadrant, you hardly get any vessels. So this is up to 80 to 90% of cases. So what we decided to do was that for MIGS, we did a ICG angiographic guided surgery. So this is a live view of the dye after injection. You can see now, this is the view of the outflow channels getting imaged. And here you can see this is the nasal quadrant, which has the maximum vessels. So wherever you have the maximum outflow vessels, you mark that area. And then in that area, you do your MIGS. So this is a bang procedure. You are cutting through the trabecular meshwork to deroof the canal of Schlemm. And you can see post-surgery, the increase in the outflow of aqueous. So this is basically, you image with the aqueous angiography, what is the area of maximum aqueous outflow. And only in that quadrant, you make a small incision so that you are targeting the area of maximum aqueous outflow. So this is an ICG aqueous guided MIGS, and this may be the future of MIGS surgery because you are localizing the exact spot of where you are operating. This was the first report that we did, the aqueous angiography guided ab interno trabecular surgery. So you localize the area where there is maximum aqueous outflow with angiography, and then operate on the trabecular meshwork within this area. If on the other hand, you operate on an area where there is low flow or no flow, then you might not get a very appropriate result. And you can see this is another patient with aqueous angiography. Now in this patient, the temporal quadrant is showing major vessels. There were no vessels in the nasal quadrant. So if you operate on this quadrant, you are not likely to get a major decrease in intraocular pressure. So you localize the area where there is maximum aqueous outflow, and sometimes it is not nasal, it may be temporal or inferior, and then focus on doing the MIGS in that particular quadrant. What about opening the canal? So this is a simpler procedure as compared to eye stent, and you can see the initial results for trabectome. So all these techniques are not very impressive in terms of IOP control. You can see IOP less than 21, only 22.4% with trabectome. And this study from Mayo, where they found that with trabectome, IOP less than 18 was achieved only in 22% of cases. And similarly, with the Kahoot dual blade, definitely you can get an IOP reduction 10 to 20%. And the KDB showed a better IOP reduction as compared to the eye stent. But both the KDB and the trabectome are expensive devices for developing countries. So why not just start the MIGS with a bang using a 26 gauge needle? So this is the most inexpensive way to do a MIGS. You just bend the 26 gauge needle, and then under the Swarm-Jacob gonioscope, you take a strip out of the trabecular meshwork 30 to 60 degree with the option of injecting a viscoelastic. So if this surgery works, it's a very inexpensive way to do MIGS, and you might get a pressure reduction anytime, anything between 10 to 20%. And so not much data is available apart from this study presented at ARGO, where 30 degrees of TM was removed. The short-term IOP reduction was 10 to 25%. So if you can get this sort of IOP reduction just with a 26 gauge needle, I think that would be very appropriate for MIGS in developing countries. Now, some people advocate to open the canal 360 degrees with the GAD procedure, and definitely this procedure can lead to a significant drop of intraocular pressure, but you can get very significant hyphemas. 1/3 of the patient may end up in failure, which you call as non-responders. But the IOP lowering is not sufficient for patients of advanced glaucoma where you require a low target IOP. And subsequently, you may have to follow these procedures with a trabeculectomy. And that is being advocated that you do a GAD. If it works, it is fine. If it doesn't work, then you do a subsequent trabeculectomy. But you should always remember, because you are rupturing the entire canal, there is always a risk of a delayed onset hyphema, especially when there is a rise in intraocular pressure due to any cause. So that is a major problem in removing the entire trabecular meshwork. That is something I feel should never be done, because you might have to restrict physical activities and Valsalva for these patients. If he is a young patient, if there is a future drug to target the trabecular meshwork, he will not benefit because you have already removed the TM. SLT is not an option. And always remember, if you do a subsequent trabeculectomy where you lower the intraocular pressure below the epithelial venous pressure, you can get reflux bleeding if you have done a GAT procedure. Another important thing to understand is that even though we are operating on the trabecular meshwork, the important thing to remember is that 25 to 50% of the resistance may be beyond the Schlemm's canal. That is a distal outflow obstruction. And once you operate on the canal, you are going to get a healing response, which may lead to failure of the surgery. So if you do a procedure such as GAT, you have a lot of pigment release and you have a fusion of the trabecular meshwork leaflets. So that can subsequently lead to failure. And there is always a risk of damaging the outflow channels when you do anything on the canal of Schlemm. The other important question is how much of trabecular meshwork to operate is bigger, better? The answer is no. There is no correlation between the trabeculectomy opening size and the IOP reduction. This was in the trabectome study. You can see small opening versus large opening, but no difference in the intraocular pressure. And this is a study comparing 360-degree versus 180-degree GAT, and you can see no difference in IOP outcomes. 360 versus 180 had similar outcome. So if you do GAT, you should only do never more than 180 degrees. And why? Because the outflow resistance as measured in enucleate human eyes, if you just remove 1 clock hour of the trabecular meshwork, 30% of the resistance is being eliminated. And if you remove 12 clock hours, 49% is being eliminated. So even with 12 clock hours, 50% of the resistance may remain. And doing just 1 clock hour produces 60% of the effect of 12 clock hours. So in any sort of trabecular meshwork surgery, never go beyond 3 to 4 clock hours. It just causes more damage and is counterproductive in the long run. The major people who are advocating MIGS say it has a better quality of life, but if you evaluate this and you evaluate the quality of life, there is no difference between MIGS and trabeculectomy. And actually, the patients in the trabeculectomy group had a lesser need for medication. So that may actually improve the quality of life over long term. And finally, should you replace trabeculectomy with a Zen or a PreserFlow? These are the full thickness implants available. With the Zen implant, definitely it can lead to a reduction in IOP. But the important thing to remember is that a very high needling rate, because it is prone to fibrosis, the ab internal procedures. And when you have such a high needling rate, it is bound that over time, these implants are going to fail. In addition, you have all these complications reported with the Zen implant, including because you are injecting mitomycin C over a very small area, you can get localized bleb thinning and blebitis. And coming to the final implant, the PreserFlow, the recent study evaluating the microshunt versus trabeculectomy has shown that the probability of success is much lower with the microshunt as compared to trabeculectomy. Trabeculectomy definitely leads to a lower target IOP as compared to the PreserFlow implant. Now, for 1 minute, let us say that the iStent 3 devices, the Zen and the PreserFlow, are equivalent to trabeculectomy. So can we adopt these procedures? The answer is no, because if you see the guidelines for adopting a new technology, if you have an existing technology that is as effective as existing technology, but is more costly, then the guideline is that this is a compelling evidence for rejection of the technology because it is not adding benefit, it's just adding cost. So to summarize, the ab interno canal surgery is good for early glaucoma and ocular hypertension. Never remove the entire trabecular meshwork. Try out the bang procedures in the nasal quadrant, or if available, use aqueous angiography guided surgery. For MIGS, if your aim is to reduce medications, please go ahead. If your aim is to achieve target IOP without medication, these are not the correct techniques to follow. Expect the IOP to rise over time and counsel the patients for a second surgery. And remember that the full thickness implants do not achieve the target IOP required for advanced glaucoma as compared to trabeculectomy. So currently with MIGS, there is a disparity between the existing quality of evidence on the effectiveness of MIGS and how widely it is being adopted by clinicians. The current usage is not strongly evidence-based or standardized. The allocation of patients to a particular type of device is without objective criteria, and their use is primarily being governed by surgeon preference, training, experience, and of course, how much money you earn with these devices. So if you ask me which MIGS is best, so I like this quote from the article by Richard Parrish, that beauty is in the eye of the beholder. And finally, if we are looking for a global solution to glaucoma blindness, let us not forget that 71% of the world population remain low income, living off less than $10 a day. So can we really impact global blindness by advocating these $1,000 implants? That is something for us to think about. And that raises the question of ethics. And I leave you with the definition of ethics. Ethics is knowing the difference between what you have a right to do and what is right to do. Thank you very much for your kind hearing.
Thank you for the talk, Tanuj. Very, very evidence-based and giving us a broad view on the efficacy of the MIGS and where it can, the misconceptions sometimes on MIGS. Let's give a few minutes for Q&A for the audience to give some, throw in some questions. Okay. Again, we're into the question and answer portion of this masterclass. I'll just throw in the first few questions. The first question is micropulse and subcyclo laser therapy similar? What is the subliminal laser therapy for glaucoma? Tanuj, would you care to answer this?
Yes, I think they are both similar types, but the micropulse is with a term used for iridex machines, and the subcyclo laser is a term used for Quantel machines. So essentially, they are the same techniques. They deliver the subthreshold micropulse laser and have similar efficacy and safety. There is no difference in the outcome between the two procedures.
Yes, so it's in the same group of lasers, the subthreshold, where the laser, the duration is lower than the thermal relaxation time of the target pigment. So yes. Again, it's quite similar. Can you, the next question is, what's the current trend for high frequency drainage surgery in drug-resistant glaucoma? What is the current trend for HFDS?
So, Tony, I have no experience with this technique, so difficult for me to comment on this.
Okay. Oh, this is a good question. The third question is, what is a good option for ocular hypertensive patients who cannot control the intraocular pressure with full medication? So I guess no optic nerve damage yet, but the pressure is elevated.
So I think the first thing is you have to see whether the patient is compliant to medication and whether he's a responder to the medication. There are some categories where they don't respond to a particular prostaglandin, that you may like to switch drug. That is number one. The second, if patient is not compliant or not happy putting the drugs, then you can try selective laser trabeculoplasty. And thirdly, what I would advocate, if the patient is amenable, if he goes into a program of meditation, mindfulness, breathing, that itself can lower the pressure, especially if there is patient is having chronic stress and there is rise in endogenous cortisol. So these patients may benefit from mindfulness meditation, focus on breathing, and it may help to lower the pressure along with drugs or laser therapy.
Okay. Any other options? I guess this question really depends on the level of eye pressure. What if you have quite an elevated pressures in the 30s and the 40s, and it's not controlled with medical therapy or with laser trabeculoplasty?
I think then you have to move towards surgical option. So in that situation, it will depend on which part of the globe the patient is and what is the access to the minimally invasive glaucoma surgery. If a patient has associated cataract, then of course you can combine phacoemulsification with any of the MIGS procedures and even with the ab interno canal cutting procedures which are low cost, such as the GAT or the BANC. But I guess if the patient has access to a place such as Singapore, then there they would go ahead doing a phaco combined with the eye stent or a hydrous device if the pressure is not controlled on multiple medications.
Okay. There's another question here. How do you prevent mydriasis from micropulse laser?
So that is something which you cannot control. And that is why this is a complication which is very significant. And the only thing I would advocate is that use low energy settings and don't go beyond 2000 milliwatt and 60 to 80 seconds. Because the higher energy or the higher fluence you use, higher are these complications. So if you have a young patient, especially from a place which is close to the equator, use low energy settings. You may require to redo the procedure, but you will end up with less complications. The patient will be happy.
Okay. How about combining? You mentioned about combining micropulse with conventional cyclodestructive procedure, 180 for each. Does that decrease the chance of mydriasis?
So, Tony, I am not an advocate of this technique because you are increasing the cost to the patient exponentially by using a micropulse probe, which is so expensive, and then using a second G probe or another probe. So I don't think it's nice to have these two technologies combined. It is better to go ahead and do a 180-degree inferior conventional diode laser with low energy settings so that the damage side effects are less. But I would not recommend this combination therapy.
Okay, thank you, Tanuj. It's quite interesting what you presented earlier regarding the ICG and angiography guided MIGS. I think this is the way to go for those who are performing trabecular bypass procedures type of MIGS. Can you explain further on what equipment is needed to be able to do this?
So this is a new device. This is the Spectralis Flex system. So you have this OCT machine which you use in the retina lab for angiography, but the patient has to be in a sitting position. So this is a new system where it's in your operation theater. It's mobile system where you can do the angiography with the patient in supine position. So this is advocated for all sorts of retinal fluorescein angiography. But for glaucoma people, these are initial studies done by Dr. Alex Huang. You can use the ICG dye 0.5% in the anterior chamber. I would not recommend to use fluorescein because that leads to a very bad staining. So if you are having a patient, you are doing MIGS along with cataract surgery. Prior to cataract surgery, you can inject the ICG dye and then use this Spectralis OCT to have a live imaging of how the aqueous drains out from the eye through the corrector channels into the aqueous veins and the episcleral veins. And although 80 to 90% patients have a nasal or an inferior nasal congregation of the outflow vessels, there are often surprises like the case I showed you where we could hardly get any vessel in the nasal quadrant. And once you see what is the area with the maximum outflow, you can mark that area, and then you wash out the dye and do your MIGS procedure in that particular area where there was maximum outflow. So with that, you can enhance the efficacy of your MIGS procedures, because if you see literature, very variable results, sometimes results are very poor. And you can imagine, like for developing country like ours, if the patient is paying 2,000 US dollars and you don't get an IOP leveling efficacy, so then you got a very sorry face and you have no idea. You have put in the device, but it's not at a location where there is aqueous outflow. So I think this is definitely something which can enhance the efficacy, and also it minimizes the area of surgery. So you can only operate on a small area of the trabecular meshwork rather than tearing out the entire meshwork for getting an aqueous outflow.
Yes, a very interesting, innovative technique. Are you aware of any study, a randomized controlled trial comparing angiography-guided MIGS procedures compared to conventional?
So no, Tony, these are very early stages, and
okay,
it is quite an expensive machine. I think it's not available in many centers. So we recently acquired at our university, so we have been able to image this. But the major studies, there's no randomized controlled trial. The initial studies have been done from Dr. Alex Wang.
It's quite promising, actually. How about just injecting trypan blue? Does it and then look to where it episcleral vessels it drains to? Does it really does it help?
Yes, definitely, Tony. That is an idea on the table. You can inject in fact, even if you do the MIGS and you inject BSS, you can see a fluid wave. Yes. And with trypan blue, you can see in the epithelial vessels. But to image actually the trabecular canal flowing through the canal into the collector channels, that requires a very high magnified imaging, which you can only get with aqueous angiography. But short of that, definitely with the trypan blue, you can see the epithelial veins and the aqueous draining through that.
Okay, thank you. Now, you've spoken a bit on the trabecular bypass procedures, subconjunctival MIGS. How about the suprachoroidal MIGS, suprachoroidal drainage devices? What's your take on that?
So, Tony, that is a totally unpredictable area, because that suprachoroidal space is, firstly, it is a dangerous space to work in because you can get hemorrhage. Secondly, you already had the CyPass implant, which was withdrawn because of the endothelial cell counts. And that space is prone to fibrosis and closure. So I think that is the last space to work on. And currently, I don't think any procedure is being advocated for the supraciliary, although there are a lot of implants which are undergoing research, and they may be there in the future, but I would not advocate, really. They have not shown a lasting efficacy.
Okay, thank you, Tanuj. There's a question from the audience. If an ocular hypertensive patient who's medically uncontrolled with highly pigmented trabecular meshwork, will you suggest SLT?
Yeah, definitely. You can do SLT, and you can titrate your energy to start with the lower level. So I think if the trabecular meshwork is visible and in patient is ocular hypertension, definitely the SLT can be recommended as a first-line therapy.
Yes, I think with the risk-benefit ratio of the SLT, you could do it, especially with the results of the LIGHT study. It's quite interesting, and it moves up in the treatment paradigm, especially in countries that the medication is an out-of-pocket expense. With regards to the subconjunctival MIGS between the Zen and the PreserveFlow, which do you think makes more sense? Because as we know, the tenons or subconjunctival space, there's a lot of adhesions. Which of these two procedures would you, they have both some advantages and also some difficulties, like the Zen high needling rate. Which one do you think is a little bit more better in terms of getting the pressures to around 16 or lower?
So Tony, I think hands-on, the pressure flow would be a better device because you are doing ab externo, you are applying wide area of mitomycin C, and that is what is going to govern the long-term success. With the Zen ab interno, it's like a blind procedure, very prone to adhesion, scarring, and the localized application of mitomycin C over a small area is bound to cause long-term complications. And if you see the needling rates with Zen, like 50% of patients require needling. That itself tells you that this device is going to fail. So as compared to Zen versus pressure flow, anytime I would say pressure flow would be the better device. But
Okay.
trabeculectomy is still better than both.
Yes. How about there's some who were advocating, not really advocate, but who are doing Zen implantation, but they still they do it ab externo. They still dissect the conjunctiva to have that dissection. Can you
Yes,
comment on
Tony,
that?
so there is a very nice study done by Professor Peng Kho, where they showed that the ab interno approach is a wrong approach that leads to increased resistance. So that is why if you have to implant these devices full thickness, an ab externo approach is definitely better because you are looking at a long-term IOP control. So being minimally invasive and not having IOP control doesn't make sense. So it is better to use an ab externo approach with a wide dissection and appropriate application of mitomycin C.
Okay. And maybe going to application of mitomycin C, even for trabeculectomy, some would inject it, some would use it as an onlay. Can you comment on that?
So Tony, I am quite scared of mitomycin C. So I have still not converted to the injection because you don't know what is going to happen in the next 10 years. So I am still using sponges and I use 0.2 milligram per ml for 3 minutes for primary surgery. And that has done quite well. So I have not shifted to the injection as yet.
Okay. But what does the evidence say? Is there any
Evidence
strong?
says there is no difference. There is no difference between the two.
Okay. I think there's no questions in the chat box, and we're out of time. Thank you, Tanuj, for that very comprehensive and evidence-based talk. I think a lot of people in the audience were able to get some insights on the place of MIGS in their practice, and maybe also to tackle some misconceptions about it. Thank you very much, Tanuj.
Thank you, Tony, and thank you to the audience. Thank you.
Okay. Okay. Then moving on. Again, I would like to thank Professor Tanuj Dada for gracing us in this masterclass. I hope everyone was found all the information presented helpful. Again, we have to be quite critical with new devices and new procedures. We need, although we shouldn't stifle innovation at the same time, but we just have to be critical about it, because if glaucoma is a lifetime disease, we do something to the patient, it will be for their lifetime. And also, I like what Professor Tanuj mentioned, that glaucoma is a worldwide disease. We want to make sure that whatever treatments that we give, it should be available widely, so that more patients can be helped. Okay. With that, I think we'll just remind for the next webinars that we're going to have. I think they're going to show a slide. Okay, so again, the next masterclass. Okay, this is just for the next masterclass that will be for 2022. We'll have a series of webinars again, and masterclass. Try to log in and also save the date for the APGS meeting in Kuala Lumpur. It's going to be a hybrid meeting. It's going to be quite interesting. Professor Dada is the scientific program chair, and he has prepared a lot of interesting sessions for this talk. With that, I'd like to thank the audience. Professor Dada, again, thank you for sharing your insights. And thank you to the audience for participating. Good night to everyone.
Thank you.